Yes, sir. You can start now, sir.
Yeah, Pratik, you can start. Pratik.
Sir, you can. Yes, sir.
Good
You can.
morning.
You can start.
Yeah, Pratik, please start.
Good morning, everyone. So, welcome to the Higgs course of early morning of 8 a.m. And thank you, sir, and thank you, Ghanshyam Sir and Srinivas, sir, for giving this opportunity. My topic is subarachnoid hemorrhage. So, I've taken this study from this three areas of 223 guidelines of in 2023 of management of patients with aneurysm, subarachnoid hemorrhage, and also from diagnosis and management of subarachnoid hemorrhage and contemporary management of aneurysm, subarachnoid hemorrhage of 2024. These all three are important, and I've read it basically and find out that these are have incorporated many more things that I've not previously incorporated. So moving ahead, the guidelines have driven from 2019 and now it's increased to 2022. That guideline management of spontaneous intracerebral hemorrhage of guideline of American Heart Association. So now the subarachnoid hemorrhage starts from a pre-hospital care on itself. That is a pre-hospital care, emergency department care, acute hospitalization care, and post-acute care and outpatient. This is like a AHA grading of like a MI or like a stroke patients. Early brain injury is the main care of a phase of care in which acute resuscitation, emergency diagnosis, prevent rebleeding, and manage of elevated ICP and management of seizure is important. And along with that, a delayed brain injury is also important to be taken care of. The delayed cerebral ischemia, sodium dysregulation, fever and temperature management, glucose management, and nutrition support, along with the recovery of a headache, seizure management, screening and cognitive and long-term outcomes. With this, the patient-centered care and family caregivers should also be given. So all three phases are to be incorporated and included in new guidelines. Subarachnoid hemorrhage is a neurological emergency, and hemorrhage in a subarachnoid space, as we all know, and less common but important cause of stroke. Most common cause is aneurysm and also the traumatic, but most common is aneurysm and mostly the anterior cerebral artery and anterior communicating artery is the most common aneurysms found in 40% over, and then along with that middle cerebral artery in a bifurcation, then a posterior communicating artery and like a basilar artery in a posterior cerebral artery. So, what's the basic behind that aneurysms? SH is predominant in women. The average age at aneurysm rupture is 53 years, and current guideline recommends if the patient has a two or more first degree relatives with aneurysm or a SH. So, what the genetic features, we find it out that mostly the interleukin 6 and gene polymorphism have an elevated risk of aneurysm formation. Several other factors are nucleotide polymorphism associated with aneurysm formation, the strong association on chromosome 9, also the chromosome 8 in chromosome 4, and these are the genes are the genetic factors lead to the formation of aneurysms. Classification of stroke, as we all know it, primary ischemic stroke and hemorrhagic stroke. Ischemic have thrombotic and embolic, and hemorrhagic is intracerebral hemorrhage and a subarachnoid hemorrhage. So SH etiology, head trauma, and the aneurysm and vascular malformations, extension into subarachnoid space from primary intracerebral hemorrhage. Mycotic aneurysm may also result from an infective emboli. These are the some images of aneurysm, how they look out in CT scan and their pictorial imaging. So, what is the pathophysiology? Subarachnoid hemorrhage is a mechanical effect of brain tissue obstruction of and by the ICH and mass effect in hydrocephalus. These subarachnoid hemorrhages can result in cerebral decrease in cerebral blood flow and decrease in cerebral perfusion pressure. The early brain injury, decrease in cerebral blood flow, blood-brain barrier disruption, and endothelial cell apoptosis lead to the cellular changes, which causes a systemic complications and also the complications related to the subarachnoid hemorrhage. So this is a normal brain tissue, and when subarachnoid hemorrhage occurs, this blood-brain barrier and this tight junction get released off and causing a release of endothelial cells, tumor necrosis factor activation, and caspases 3, which causes the inflammatory markers. As the aneurysm develops, it typically forms a neck in the dome at the site of rupture, with that the wall thins out and tears along the bleeding of 0.5 mm long. When the bleeding ruptures out, this is that much long. Aneurysm size and the site are important predictors of risk of rupture. Those more than 7 mm, this is very important that those more than 7 mm and at the top of basilar artery and posterior communicating artery and anterior communicating artery are greater risk of ruptures. So these are the points that we remember in future of the slides, that these are the slides and our treatment depends on these diameters also. One theory is that what's the mechanism of formation of aneurysm is that developmental defect in media and elastica. Other theory is that focal destruction of internal elastic membrane caused by the hemodynamic forces. As a result, a local weakness in vessel wall intima bulges out and convert into adventitia. The sac gradually enlarges and subsequently ruptures. So what is secular and aneurysm, which is most common? Autopsy and angiography studies have found that 2% of adults harbor these aneurysms. Size is mostly 2 mm and can extend to 2 to 3 centimeter. Average size is 7.5 mm. Those which ruptures are usually 10 mm more or more than, but smaller ones can also get ruptured in different form. So it doesn't mean that 7 mm only ruptures, but small mm can also get ruptured, but they have a hallmark on that. That is patent artery, but narrow stalk. Some others may be broad based without stalk and have a cylindrical form. So these small forms of aneurysm can also rupture. So these are the barrier aneurysms to look like. If the patient survives but aneurysm is not obstructed, the rate of rebleeding is about 20%, 30%, and 3% per year afterwards. The aneurysm, the annual risk of rupture of aneurysm is less than 10 mm, its size is 0.1 mm, 0.1%. But when the size increases to more than 10 mm, it's more than 0.5 to 1%. And mortality is very high as the percentage increases. Giant aneurysms, those more than 2.5 centimeter, as I already said, that's above more than 2.5 centimeter, about 5% cases. The three most common locations are terminal internal carotid artery, middle cerebral artery, and top basilar artery. So these are the points to remember, that we found most of the city when angiography or DSA is done, then most of the areas we find out this area. Their risk of rupture is 6% in first year after identification and remain high indefinitely. They often cause symptoms by compressing the adjacent brains and cranial nerves. Risk factors, as we all know, polycystic kidney, fibromuscular dysplasia, myoma, and coarctation of aorta. Patient of subarachnoid who arrive live at hospital, mortality rates about next is 45%. And those who survive, then morbidity is more very high, that is 50%. In initial hemorrhage, cerebral vasospasm, and hydrocephalic valve are most of the complications that we found that lead to the morbidity. So these are the scores and outcome, and we are evident with that. Hunter score and World Federation is going to predictive outcome of this, and modified Fisher said about the vasospasm. So Hunter has and World Federation neurological surgeons said about the outcome, predict the outcome of the SH, and modified Fisher tell about the vasospasm, that how much chances of vasospasm is there according to the grading. So the outcome of delayed cerebral ischemia associated with clinical and radiological scales, as I have already told you, that World Federation and WFNS tell about the predictor of outcome, and most reliable and validated radiological score is modified Fisher scale, which tell about the delayed cerebral ischemia. So as we all know, the natural history of outcome of the adrenal subarachnoid hemorrhage, recent combination of other scoring is also there. That is Fisher, clinical grade scale, composite scores such as Vasograde score, Hare scale, which is known as Hunter-Hess scale, age, IVH, and rebleed, Sachet, trials list, and SH scores. So these are the new scores that is incorporated in the guidelines, but you don't have to remember all. Just for the exam purpose that we have to remember, these are the other grades that are incorporated. So in patients with high grade of SH and aneurysm, treatment is reasonable after careful discussion of likely prognosis with family members and optimize the patient outcome. So this help to about the, which is most common, that communication, that patient outcome should be depend after doing the Hunter scale. So you have to be you have to tell that your attendants that this grading is at this bar and this is the outcome of this patient at this grading. So the recommendation of clinical manifestation and diagnosis of SAH in patient with acute onset of severe headache, prompt diagnosis of workup, violation of recommended diagnosis of SH is mortality. Now the new scoring is also included in patient with acute onset of severe headache without a new neurological deficit. Application of Ottawa's rule is incorporated. So Ottawa's rule is like that, is that we it is a there is a scale, or there's a number of risk factors which tell you about the patient has a aneurysmal subarachnoid hemorrhage. So most of the unruptured intracranial aneurysms are completely asymptomatic, which are sentinel bleeds. Symptoms are usually due to rupture of SH. Patient is stricken with severe headache and vomiting. and which is the most thunderclap headache, and which is the most severe headache, does not feel again, and which is not have felt anyone in their lifetime. So falls of unconscious immediately. Several severe generalized headache occurs suddenly, but patient remain lucid with a varied degree of neck stiffness. Rarely patient become unconscious, but who become unconscious can die in minutes to hours. So this is the workflow of a patient with symptoms of concerning of subarachnoid hemorrhage. If patient has headache, it doesn't mean you have to apply the Ottawa rule that I'll discuss in my successive slides. What is Ottawa SH rule? And at a physician discussion, this class 2B recommendations. If less than 6 hours headache is there and no neurological deficit, then non-contrast CT. If you find no SH, then work of a physician. If SH is there, then DCT, CT angiography or DSA. Similar like that is more than 6 hours, neurological deficit, non-contrast CT, SH you found, CT angiography. If no SH is found, then lumbar puncture. But if because the new neurological deficit in 6 hours more, headache time is there. And if you find xanthochremia, then treatment according to the SH. So this is Ottawa SH rule applied more than 15 years of age more than 40 years, neck pain, witness loss of consciousness, onset during exertion, thunderclap headache, and limited neck flexion. This is the most common indication the patient have a SH. In 45% of cases, severe headache associated with exertion in presenting the complaints. The patient often calls headache the worst headache of my life. And most important characteristic is a sudden onset. Sudden unexplained headache at any location should raise a suspicion of SH, must be investigated. So you can have a pain at other sites also, like occipital and posterior cervical spine also, pain and behind the eye also, and a low temple can occur in a middle cerebral artery aneurysms. Loss of consciousness is another feature of a subarachnoid hemorrhage as the ICP suddenly rises. In 10% of cases, aneurysmal bleeding is severe enough to cause a loss of consciousness. Although sudden headache in the absence of focal neurological symptoms is hallmark of aneurysmal rupture. Anterior communicating artery and middle cerebral artery bifurcation aneurysm may rupture into adjacent brain and subdural space, forms a hematoma large enough to produce a mass effect, which causes a loss of consciousness and neurological deficit. Third nerve palsy is another cause of neurological deficit, which is seen in rupture of aneurysm or in aneurysm subarachnoid hemorrhage. Junction of posterior communicating artery and posterior cerebral artery aneurysm is there. Indication of that. Sixth nerve palsy is the aneurysm is cavernous site. So according to the aneurysm site, you can see the palsy of the areas. Unilateral blindness in the ophthalmic area, that is in circle of Willis, origin of ophthalmic artery. Hemiparesis nephriosis suggests aneurysm is a bifurcation of middle cerebral artery. So according to this trial, which is released in 2023, in a retrospective study, which says that bleeding, 81% of patients with unfavorable outcome had a loss of consciousness, while only 3% have a favorable outcome had a loss of consciousness, who had a loss of consciousness. So loss of consciousness is a strong predictor of poor outcome after non-arousal SS, because we don't know for how much time the patient has a loss of consciousness and have a worst outcome in that. As we see in that, that is a significantly p-value significant in GCS score when there's a change in WFNS scoring, that is 4 and 5, and also in a patient of vasospasm, hydrocephalus, and ventriculostomy. So these are the risk factors that loss of consciousness, World Federation Neurological Society of 4 and 5 grading was vasospasm, and the hydrocephalus ventriculostomy is a grading that lead to the that have a risk of mortality in the higher chance of unfavorable outcome in loss of consciousness patients. So there's other DD also, thunderclap headache, symptomatic drugs can also causing a headache and sudden severe headache. So you have to rule out other DDs also in headache cause. Cerebral venous thrombosis, diffuse vasospasm, pituitary apoplexy, hypertensive encephalopathy, intercerebral and extracranial arterial dissections. What is the investigation? Which is the most important part. CT scan is the most common initial procedure that to be done, a non-contrast CT scan to locate the underlying aneurysm, identify the cause of any neurological deficit, predict the delayed vasospasm. A high incidence of symptomatic vasospasm in the middle cerebral artery and anterior artery has been found when early CT scan is done. Show a subarachnoid clot of 5 into 3 mm in basal systems and layer a blade of more than 1 mm thick, which is called about the Fisher scale. A CT scan less reliably predict the vasospasm in vertebral and basilar and posterior cerebral arteries. So these are the sites of we see the blood in non-contrast CT scan. That convexity of subarachnoid hemorrhage, subarachnoid space, and lobar intercerebral hematoma can also lead to. So imaging studies, collection of blood can also be defined according to the which artery get ruptured. So collection of blood anterior interhemispheric fissure indicates anterior communicating artery. Blood in sylvian fissure, that is middle cerebral artery. Blood in anterior perimesocephalic cisterns, posterior communicating artery. And MRA can also detect the blood in a proton density sequence. So angiography is a gold standard. There is a digital subtraction. Angiography is a gold standard four vessel. Also, the extra intracranial vessels need to be included as a multiple aneurysm occurs in 20 to 30 patients. Cytoangiography is an alternative method for locating an aneurysm and may be sufficient to plant a definitive therapy. 5 to 10% of aneurysm bleeds. There may not be evidence in aneurysmal rupture. Perimesencephalic syphilic hemorrhage also carries a better prognosis because in this system surrounding a midbrain and upper bones get filled with blood. Easily can you find it out? Mild headache, no vasospasm. The chance of vasospasm very less, so mortality is very low. Usually no aneurysm is found at expected site at the top of the basilar artery. Lab investigations, if you find out that there's nothing in CT scan, then you have to go for a lumbar puncture. So lysis of blood in red blood cells and subsequent conversion of hemoglobin to bilirubin stain the spinal fluid yellow within a 6 to 12 hours. And how you have to diagnose that is hallmark of subarachnoid hemorrhage. This is a main finding: an elevated opening pressure, an elevated red blood cell count that does not diminish from cerebral blood flow fluid, cerebrospinal fluid to 1 to 4. That is hallmark of SA. The four main causes of complications, that is rupture, hydrocephalus, vasospasm, and hyponatremia. So this is a pictorial graphical presentation of aneurysm rupture, blood in a subarachnoid space, high ICP, extremely severe cases, cerebral blood flow arrest or a death can be occurred if there's a high ICP is there. Then there's a systemic consequences and the cerebral consequences. In systemic, you see the cardiac complications, hyperglycemia, and neurogenic pulmonary edema. And in cerebral consequences, with blood-brain barrier opening, then there's a microcirculatory dysfunction, cerebral edema, oxidative cascade, then DCI, vasospasm, hydrocephalus, and seizures. So re-rupture is same site in more than one third of the patient. The incidence of re-rupture if SAH is more than 30% and peak in 7 days. Predictor of rebuilding is include Hunter case grade 4 and 5 is the most common that they most of the chances that chance of rebleed. The cause of reoccurrence is not clearly understood, but appearance of related to naturally occurring of clot lysis that can lead to re-ruptures. So the medical measures to prevent rebleeding is that you have to control the blood pressures. Severe hypertension, avoid severe hypertension. Hypertension and blood pressure variability is also avoided. So who are receiving anticoagulations should be go for anticoagulant, should be antagonize the anticoagulants with the who are the drugs of anticoagulant can give a idrasumab, adenosine alpha, the new antagonist of that, and should receive the can also receive a tranexamic acid, but not much evident and not much trials are done on it. Hydrocephalus is another complication which can cause a stupor and coma, occurs mostly over a few days and weeks and cause a progressive drowsiness and slowed mentation and with incontinence. Chronic hydrocephalus develops weeks to month after SOH and present normal pressure hydrocephalus, but not much chances of morbidity. Vasospasm, which is most common complication found in 30% of the patients and occurs in 4 to 14 days, and you have to be evident on that this may occur in most of the patients after hemorrhage and most often at the 7 days. The severity and distribution of vasospasm determine whether the infarction will occur. The most common cause of delayed cerebral ischemia after SH is assumed to be the vasospasm. Vasospasm believed to result from a direct effect of clotted blood and its breakdown products of in arteries in the subdural space. All these focal symptoms present abruptly, fluctuate or develop over the few days. Severe cerebral edema in patient with infarction from vasospasm may increase the ICP enough to reduce the cerebral perfusion pressure. So the modified Fisher scale, we all know that tell about the likelihood of the cerebral vasospasm. The transcranial Doppler sonography is useful for detecting the monitoring the vasospasm of SAH patients. So what other things you can do to define or to find out the vasospasm, excluding the confounding factors like sedation, hyperthermia, and other confounding factors, and neuromonitoring, which is most common nowadays, like to see the pupillary sign with the pupillary transcranial Doppler to see the mean flow velocity if more than 120 centimeter per second, or increase the 24.5% from the basal, that is the rise of the wave from the basis 24.5% rise of a Lindy-Gard ratio of more than 3. Increase in ICP more than 20 mFHg, seizures of EEG more than 10% decrease in of alpha and delta ratio, and low brain tissue oxygen meter, that is brain tissue oximetry less than 20 mFHg is signs of there is a signs of vasospasm is there. Hyponatremia is another complication we see in first 2 weeks. Both atrial natriuretic and brain natriuretic have a role in producing a cerebral salt wasting syndrome, but you can also see the SIAD features also. So most that it doesn't mean that one patient doesn't have SIAD and one patient can have a cerebral salt wasting syndrome. Both the things can occur same time in same patient also, which causing the hyponatremia, but the treatment of both the things are different and you have to be evident on that. Typically it clears over the course of 1 to 2 weeks. Systemic changes associated with SAH like elevated CPK, ICG changes, circulating catecholamines causing a non neurogenic pulmonary edema, diabetic insipidus, albuminuria, glycosuria, and leukocytosis. ECG changes, ST and T segment changes, ST elevation, T wave inversion. That is called the cerebral T wave. Intercerebral hemorrhage when it is the cerebral T waves. These are like a ST elevation, okay, and this is like a cerebral T wave, which is look like, okay. Echo, we can see the regional wall motion abnormality that flow the distribution of sympathetic nerves rather than major coronary artery. So the echo doesn't show there is any coronary disruption, but because it is related to the catecholamine surge, which causes a regional wall motion abnormality. But when the in a subsequent time, when the brain tissue or catecholamine surge getting decreased of, the wall motion getting improved of. Treatment protecting the airways is the most common ABC, airway, breathing, and circulation, managing the blood pressure, preventing a rebleeding prior to treatment, managing the vasospasm, treating the hydrocephalus, treating the hyponatremia, and preventing the pulmonary embolus. How to prevent a rebleed? As I've already told you, that provide the variation in the blood pressures, adequate hydration to avoid the decrease in blood volume produced by the brain ischemia. How to avoid rise in intracranial pressure? Intracranial hypertension from falling the enzymatic ruptures occurs secondary to subarachnoid blood, parenchymal hematoma, acute hydrocephalus, loss of vascular autoregulation, perineal edema. ICP monitoring is important. This is more important, including a GCS less than 8, neurological deterioration, acute hydrocephalus, cerebral edema, intracranial mass lesions, and need of perioperative draining of cerebrospinal fluid. The gold standard of ICP monitoring is via the ventricular catheter connected to the pressure transducer, like a arterial line. How you do the ICP management? Head posturing, elevating the head of the bed 30 degrees Celsius, 30 degree pharmacological interventions, osmotherapy, hypertonic saline. Mannitol may still be used, but with the caution, according to patient of renal dysfunctions, as because of catecholamines can causes a renal spasm also, renal vessel spasm also, sedation, analgesia, and surgical options. If required, then surgical intervention should be required for decompressive craniotomy. And avoid minimizing the stimuli could increase the ICP, like tracheal suctioning and important during the management. Managing the blood pressure. So the recommended systolic blood pressure is not something guideline related, but whatever the guideline, the ISET trials and all the trials have done on blood pressure, that is 140 to 160 initially to reduce the risk of free bleeding while maintaining the adequate cerebral perfusion pressure. So this is a blood pressure management after intracerebral and subarachnoid hemorrhage. This is a guide taken from the guidelines of stroke of April 2022. And management of seizure activity is controversial. So Safari score may help to identify the risk of the patient having a convulsion in hospital of seizures based on older ages, rehospitalization seizure, rupture of anterior circulatory aneurysm, and ventricular drainage. Phenytoin is now not used at all. Now the new generation anti-seizure medications are used like levetiracetam. Managing a vasospasm is a leading cause of morbidity and mortality. Treatment is calcium channel antagonist. We all know nimodipine, 60 milligram per oral every 4 hourly, or if the patient is intubated with the RT tube, perhaps by preventing the ischemic injury. Nimodipine can cause significant hypotension in some patients, which may worsen cerebral ischemia. We have to be cautious about it. Early definitive therapy of aneurysm enables the maintenance of euvolemia is important. That is, now the triple H is excluded. Now the dual H, that is the blood pressure management, not avoiding the hypertension, and the euvolemia. Okay, not hyperhydration is required, just a euvolemia is required. Managing the hydrocephalus resulting from extravascular blood blocking the cerebrospinal fluid circulation to the subarachnoid cisterns. So the ventricular EVD can be put. Chronic hydrocephalus permanent ventricular shunting is treatment of choice. Role of steroid is not recommended nowadays. So this is the whole summary of the complications with their management: rebleeding, then hydrocephalus, intracerebral hypertension, DCI, and seizures. So what is the interventional management? Re-rupture and rebleeding. The safe application of techniques improve the blood flow and should symptomatic vasoplasm may develop, and aneurysm can be clipped or the coil. So that surgical clipping can be done or coil can be done according to the size of the aneurysm. Huntington scale helps in assessing the patient before deciding which management should go on. So it helps the management part also. So current approach to go for intervention within 24 hours, this will prevent a rebleed, will allow the measures to be taken. Grade 3 patient, if their conditions allow, they too will be benefited by the process of clipping and coiling. But grade 4, the outcome is generally poor. If you do the treatment, generally the outcome is poor. So about the management of according to Hunter scale in patient with subarachnoid hemorrhage with Hunter scale grade 1 and 3, 1 to 3, early aneurysmal repair results in good neurological outcome, that is 70 to 90%, with the mortality is rate only 1.78%. But aneurysmal SAH with grade of Hunter 5, 4 and 5 may benefit from endovascular surgery, but prognosis remains the poor. So surgical repairs like that involves placing a metal clip in an aneurysmal neck. I'm not doing a detail of surgical repair. Like endovascular technique involves placing a platinum coil, other embolic material within the aneurysm via catheter that is passed from the femoral artery. This will look like the coiling look like. So endovascular, the ISET and the Brett trial comparing both treatment modalities have shown that despite higher rates of aneurysmal obliteration with open surgical treatment, functional outcome at the end of the year is better with the endovascular treatment. So endovascular treatment is more evident or more required treatment and more pronounced treatment for the therapies of the aneurysms. So surgical treatment may be ideal for patient with who is required surgical clipping, just for the knowledge, with the large intercerebral hematomas resulting in raised intercerebral pressure, focal neurological deficit for patient with younger age than 40 years, and who require the endovascular posterior circulation aneurysm, poor grade of the World Federation Neurological Society classification 4 and 5, elderly, and so the young required surgical, elderly required the endovascular coil. So to sum up, SOH is neurological emergency. It is less common but an important cause of stroke. Of most common presentation is an excruciating headache, which all know that is thunderclap headache. CT scan is helpful in making diagnosis, differentiating it from other headaches also. If CT is negative, then CSF finding. If other CT and CSF is inconclusive, then DSA. Complications include re-ruptures, hydrocephalus, vasospasm, and hyponatremia. Management include bed rest, clear airway breathing and circulation, managing a BP, adequate amount of fluids, not hypervolemia, euvolemia, monitoring the hyponatremia, preventing vasospasm, measures to lower the ICP. One-third patient are prone to develop rebleed, so you have to care of it, and early clipping and coiling should be done. Randomized trial instead have showed coiling is superior to the clipping part. So this is sum up of the whole of the treatment in one page. How the subarachnoid is made, what are the treatment you have to do, in what is the ABCD approach of an emergent management of the subarachnoid hemorrhage. Thank you.
Thank you, Pratik. It was a very comprehensive but crisp recap of the principles of management of subarachnoid. Those who are appearing for exams, I think this is the best you can get in terms of reviewing the topic comprehensively. Just a few points to add. When you discuss about subarachnoid hemorrhage and its complications and its manifestations. It's always good to divide it with neurological complications and non-neurological complications.
Yes, sir.
Subarachnoid hemorrhage is a systemic disease, and certain conditions like neurogenic pulmonary edema, hyponatremia, renal dysfunction, they all are associated with subarachnoid hemorrhage as part of the systemic inflammatory response, which blood in the subarachnoid space produces. That is first point you need to understand. The second point I would like to add is among the causes of neurological deterioration and poor GCS for patients with aneurysmal subarachnoid hemorrhage, apart from vasospasm, delayed cerebral ischemia, and non-convulsive status epilepticus, cortical spreading depolarization also is an important aspect, which is quite similar to non-convulsive status epilepticus, but has a different pathophysiology and a different um, implication for the ultimate outcome of these patients. With the increased use, with the increasing age of our patients, increasing use of novel anticoagulant agents, the incidence of subarachnoid hemorrhage from trauma and other causes, non-aneurysmal subarachnoid hemorrhage, is also increasing. The point of difference is vasospasm is not a very significant component of traumatic non-aneurysmal subarachnoid hemorrhage. So you need to understand that the breach in the blood vessel wall is an important trigger, and the presence of the hemostillerion outside triggers this vasospasm, which is not a common feature in non-aneurysmal subarachnoid hemorrhage. So lastly, as with all aspects of critical care, sonography is an important adjunct in the assessment of patients with subarachnoid hemorrhage. Like all intensivists have learned lung ultrasound, echocardiogram, VEXAS, we also need to learn the art of doing a transcranial Doppler, because certain important decisions of management are linked to your assessment of the velocities of patient in this anterior circulation and middle circulation in patients with subarachnoid. So I think it was a very good, crisp recap by
Yes, sir.
Pratik.
Thank you, sir.
Anybody has any queries, comments, or clarifications, please do post them on the group from where you got this link from, and we will answer them at the earliest. Till then, please join us again. The next week, we take a break because of Pongal Sankranti in this part of the country. We will be back again on the 21st of January with another session on Higgs platform. Please do subscribe to our YouTube channel, and have a good day. Bye bye.
Thank you, sir. Thank you very much, sir. Good night. Good day, sir.